Let's talk about aging patients. So this is more generalized exemplar because there's many interesting things that happen. The causes are just you just age. Like everybody ages, kind of like menopause. Women get menopause. This is a cycle of life is to age. So when we think of our Erickson development, we're going to think of despair versus integrity. The young old is considered 65 to 74. The middle old is 75 to 84, and the old is 85 to 100. So these are classifications. There's three. Just be aware there's three different theories. There's developmental theories like Erickson. Psychosocial theories would be like your continuity theory, your activity theory, or so those are examples of psychosocial theories, and your biological theories like your free radical theories like of aging, immunity theory, endocrine theory, things like that. So just be aware of the theories. So the assessments we're going to be wanting to look at is the fall risk assessments. There's one that's called Heinrich 2 fall risk model. So it bases it on multiple factors. So if an older person goes to the hospital, they want to be able to assess that fall risk. So based on gender, mental, emotional symptoms of dizziness, known categories of medications that increase the risk used in care settings. So you want to think about that. Okay. The functional status scale is also really helpful to assess for. So we have our CATS and we have our Lawtons. CATS is instrumental, and Lawtons is ADLs, just your basic ADLs. So for your CATS, it's going to be like determining the continence and maintenance of life skills such as prepare to write a check, or shopping, preparing for meals, makes phone calls, managing finances, meaningful ways to assess function because of the skills are prerequisites. So prerequisites to independent living basically is the main takeaway. But then the basic ADLs of just taking care of yourself is bathing, dressing, toileting, transfer from bed to chair, continence, and feeding, which would be under the Lawtons. So ADLs versus IDLs are helpful functional tests to see if the patient can live alone or not live alone, where it's really important to assess. All right, some cognitive assessments. Instruments could be your geriatric depression scale and your mini-cog scale. Your mini-cog scale is like a very quick exam. It's just a 3-minute exam that will like test on the clock drawing or test. It's a mini mental exam. Your geriatric depression scale, since depression is really prevalent when you get older sometimes, like 1/3 of the population has depression. There's long-term and short-term forms available. Remember to assess the short form first, because you may not need to proceed to the next form. Also for the nutritional status, so we're assessing the cognitive as well as the functional and the fall risk, we want to assess their nutrition. Ask when the patient's last meal was. That's one of the best kind of questions you can ask. There's an M&A, which is a short form quarterly you would be given quarterly for institutionalized older adults like in nursing homes, and yearly for community older adults, so assessing for malnutrition. That is what M&A is for, so malnutrition, nutrition assessment. There's a scales assessment that is more specific, and it stands for something. That was dramatic. So scales. Scales assessment is basically assessing for this acronym called SCALES. So S stands for sadness or mood changes, or cholesterol is high. So C for cholesterol is high. Albumin is low. Loss of gain or gain in weight, eating problems or poor dentitions. So S for sadness, C for cholesterol is high, A for albumin is low, L for loss or gain in weight, E for eating problems or dentitions, S for shopping or food preparation. So this is the acronym called SCALES to assess for older patients of what we're looking for of negative or positive. So we break it down between myths and realities of what we're going to be seeing in patients. So it's actually a myth. Older adult people cannot learn complex skills. This is not true. They possibly can actually. It just depends on the cognitive function. And Alzheimer's is not associated with aging. It's just a disease that's happening and it's becoming prevalent. Inevitable declines in all intellectual abilities is not true. People consider old at age 65. That's not true. The old naturally withdraws from society. This is not necessarily true. Older psychological growth is incomplete at this stage. This is not true. So these are just some myths that we need to debunk and take out the stigma from it. So most adults past the age of 65 are demented. Not true. Sexual interest declines with age? Actually, no. Older adults are unable to learn new tasks. This is not true. As an individual ages become more rigid in their thinking and set in their ways. This is not necessarily true as people would think. The aged are well off and no longer impoverished. This is not true. Many people have financial difficulties. You know, the government wants money from the nursing homes, or you don't know. Most older adults are infirm and require help with daily activities. It just depends on their functional ability. Most adults are socially isolated and lonely. So this is debunked, and they're being too generalized. But the realities we gotta face. So what are the realities that we're gonna see? They are capable of learning new things, but the speed in the process does become slower because of those neurotransmitters. Never lose the capacity for psychological growth. Be aware of that. Older people are each a unique individual and respond differently to aging. 1/3 do have depressive symptoms, but not all of them. So it also depends. Do they maintain relationship with their families? So there's many factors to think about. People feel old based on their health and functional ability rather than their chronological age. So the senses of vision, hearing, taste, and smell do decline with age. Muscular strength decreases with age, so muscle fibers atrophy and they decrease in number. So it's going to be they're going to have more fat. Regular sexual expressions are important in the maintenance of sexual capacity and effective sexual performance. So they still have sex. They just need to adapt. At least 50% of the restorative sleep is lost as the result of aging. So they lose that good quality REM sleep. And older adults are major consumers of prescription drugs because high incidence of chronic diseases. So there just happens to be a lot of incidence of chronic diseases, and they happen to be statistically big chronic users of these. So then we're going to break it down between the myths and realities now that we debunked and we understand what's real and what's not. There's physiological factors and then there's psychological factors. So physiological factors go really in depth. There's things to think about, like the musculoskeletal system, the nervous system, cognition, the cardiovascular, the respiratory, genitory, urinary, oropharyngeal, and GI. So our musculoskeletal system, I'm going to briefly go over. You're going to have that increased weakness and poor exercise tolerance, reduced cartilage, which is the reason for arthritis. Lean body mass is replaced with that fat redistribution of fat, so they have more fat. Bone loss of men and women, which are peaked actually at 30 and 35 years old. Decreased ligament and tendon strength, invertible disc degeneration, which means that cartilage again. Articular cartilage erosion, as well as changes in stature with kyphosis and height reduction are associated with age. So that's the musculoskeletal system. The nervous system, we're going to see decreases in neurons and neurotransmitters, modifications in the cerebral dendrites, glial support cells, synapses, and compromised thermal regulation. Short-term memory and primary memory remains relatively stable. Visuospatial tasks such as drawing and constructive ability declines with age. Accumulation of practical experience or wisdom still continues to the very end of life, unless, of course, there is a disease process like Alzheimer's, which is not part of the normal process of aging. Cardiovascular, you're going to see the arterial wall thickening and stiffening, so it's going to get stiff. Decreased compliance, so it's not going to be as flexible. Left ventricle and atrial hypertrophy. Sclerosis, plaque, so think of plaque in your arterial and mitral valves. Strong arterial pulses, diminished peripheral pulses, cool extremities, decreased contractile strength, decreased cardiac output. So it's just not working as good as it used to. So after cardiovascular, we want to talk about respiratory. Respiratory, we're going to have decreased respiratory muscle strength, so stiffer chest walls, just like we had stiffer blood vessels. Reduced compliance, diminished ciliary and microphage activity, so in like our nose. Drier mucous membrane, so you're more at risk for infection. That decreased cough reflex, that's dangerous. Decreased response to hypoxia and hypercapnia, and decreased lung expansion, as well as the costal cartilage. So a lot of things with cartilage become a lot stiffer, not as pliable. Our genitourinary, there's a decrease in kidney mass because your kidneys are, a lot of things are metabolized through there, and that's the reason. So blood flow, the GFR, the glomerular filtration rate is 10% decrement each decade. It goes down after age 30. A decrease in drug clearance, reduced bladder elasticity, so it's not as elastic, so it doesn't rebound back as much. And muscle tone, increased post-void residual. Nocturnal urine production, so they get up. In males, prostate enlargement with risk of the BPH, and women get menopause, so both genders, that includes genitourinary. Our oropharyngeal and GI is decrease in muscle mastication. So the muscles that for your mouth, taste and thirst perception. I hear thirst perception a lot. Decreased gastric motility with daily emptying, atrophy or protective mucus, COSA malabsorption of carbs, vitamin B12 and D, folic acid and calcium, impaired sensation to defecate, reduced hepatic reserves, and decreased metabolism of drugs. So that's everything you need to know for that. So basically, these are the things to consider, as well as psychosocial.
Eat your food.
Psychosocial, thank you. Psychosocial.
You're welcome.
Psychosocial, that's just my sister, so.
I'm not your sister, I'm your slave.
All right, so that, introducing on YouTube, that is my sister.
That's not your sister, I am your slave.
She gave me food, that's very nice of her, and at least it's kosher. So for psychosocial, we're going to be looking at sexuality, how's their health, death. They may be having needing coping help. So they may feel social isolation, retirement, housing and environment. So these are things to think about with these older patients. They may be struggling and they need help and therapy to help them. So social isolation is not all patients. So you have to mind that each individual will react differently to old age and what is going on around their environment. So also as well, polypharmacy is a big problem with the older population. There's an increase for falls and drug interactions because having multiple drugs can cause risk for interactions and they can just fall because of that. Adverse reactions, vast amount of reactions are dose related. Older adults often have signs are different, impaired cognitive, thinking, dizziness, all that. So delirium is often associated with older adults. Non-adherence is often intentional because expense, unpleasant side effects, and not needed, and they think it's not needed for the dosage prescribed. So make sure you tell those patients that they do need it and you need to follow the full course. Like let's say it's an antibiotic, you need to follow the full course. You got to educate the older population because they just decide, oh, it's too expensive. So you may want to give them an alternative of cheaper medication. Also, because of the organs not functioning as well as they used to, like your liver and your kidneys, where there's the drug passes through to be metabolized, it's really important to know the changes because it makes us providers need to make, and we're going to be focusing on the liver and the kidney. That's the main thing. So the absorption rate, the rate of absorption may be just slow. Just be aware of that. So the effects may take a little longer, but that's not the main reason for issues. The distribution is the main thing we want to look at is increase in body fat, increases absorption of lipid-soluble drugs, as well as they decline with water, mass water. So they'll have soluble drugs become distributed in smaller amounts like ethanol, albumin, ethanol. And this is because they have less they don't absorb water-soluble drugs as easily as lipid-soluble drugs because of that more fat they have. Albumin is only slightly reduced in healthy older adults, but in a malnourished older adult, you would think of the drugs that require binding for a protein albumin could cause like high levels of the drug just being available in the blood, which could be toxic. So you have to know how the drug reacts, because if the drug is a protein binding drug, it just may randomly be floating in your blood because there wasn't enough binding for albumin if that patient was malnourished, which is an issue in older adults sometimes. So some interventions we're going to look at is the size of the needle. Consider the size of the needle for these patients. Because they have more fat, they may need a bigger needle to get through. Just think about that. Our wellness, what are we looking for? Physical nutrition and exercise, emotional family needs, mental activities such as hobbies, problem solving, just things to think about. Spiritual, faith, meaning of life. They may need help just having that integrity versus despair. Financial security, independence, and flexibility. So their independence, the goal is to try to make them feel the most independent they possibly can, depending on their functional assessment and looking at that CATS and Lawton IADLs and ADLs. You want to encourage exercise, physical and cognitive health, as well as promoting healthy diet, because nutrition, you want to make sure that they're eating adequate enough of protein, eating healthy diets to lower that cholesterol. For older patients, safety is priority. You want to prevent falls, as we discussed with assessments. That's why the assessments are out there. Make sure that they have a good support system. Do they belong to a family or community? Because you don't want them to feel socially isolated, especially since they don't have a job anymore. They don't have a place to go as much, or they may choose to go back to their jobs if they're feeling isolated. Or other things to look at, ask them what they like for leisure activities. Ask them what they like before you just start throwing ideas out there, because they may not like to watch TV. So just things to think about. Vaccinations are really important. People over 65 are more at risk for just getting sick in general because their immune system's not as strong as it used to be. So the flu vaccine is very important to tell them, which everybody should get a flu vaccine. I have to get it for school. Shingles, they may have had chickenpox, so they may need a shingles vaccine. Pneumonia is the main one to think about when we think above 65. Some complications there are for older aging adults is polypharmacy. Monitor those drug interactions, be aware of them. Tell the doctor if you suspect something is not interaction, don't just let it go. Fall risks, more sensitive to drugs, as we mentioned earlier. There's a decline in metabolizing within the liver and the kidneys. They may not be as prime as good as they used to be, so they take longer, or they may have liver failure. Be aware of the liver failure or the kidney failure. Non-compliance, often associated with cost, unpleasant side effects, believes dosage is too high. Other things to consider when it comes to medications, there also is, so Alzheimer's is not part of the regular part of aging, but it's just really important to know that Alzheimer's has been really prevalent in our society, and there are 2 drugs out there called memantine, which is also known as Namenda. And basically how it works is it doesn't really cure Alzheimer's at all, but what it does is basically has this receptor, and it binds, it has the little extra receptor to the side that will bind to glutamate and close up the door so that the cells, so that molecules won't go in. Because usually when glutamate molecules come in, it will help, but if the party inside the cell becomes too crowded, it can actually kill the cell. So this is often what medical people think is that this excitement of glutamate in the cell is actually associated with cell death, and so they're trying to slow down this. So what they do is they have this binding receptor site to this, which closes the door and allows nothing to not come in, which is glutamate. So Namenda is supposed to try to slow down the progression or help slow down the progression, but there's still side effects to consider with memantine. Like dizziness, headache, confusion, constipation, hypertension, diarrhea, weight gain. There's just a little things to consider. So basically, we know what it's for. So it binds to glutamate, an excitatory neurotransmitter, so you don't let it in. As well as it's administered orally, oral solution, used syringe, swallowed, extended release capsule. Then you make sure if it's extended release capsule to not crush it. So these are things to be thinking about. Entire capsules may be able to sprinkle on applesauce, so the way you administer it is important. It would be contraindicated in the medications that increase the urine pH, carbonic anhydrase inhibitors, sodium bicarbonate, may decrease excretion and increase blood levels, so just know that. And some patient education and instruction regarding how and when to administer, fall precautions for dizziness, as well as improvement may take months. What you're trying to evaluate as the nurse is it working? Does it decrease symptoms of dementia? Does it not slow the progression? Does it slow the progression? Cognitive enhancements, improved ability to perform simple tasks, but it's not a cure. And let the caregivers know that this is not a cure. This is just the best you can do. The other medication is cholinesterase inhibitors, and examples is Donzepil, Aricept. So those are examples. So what cholinesterase inhibitors do is it inhibits the choline enzyme that usually eats it up. So if you prevent the enzyme that usually eats up the leftover acetylcholine, you're actually preventing it from being eaten up, if you think about it. So there's more acetylcholine available in the synaptic area. All right, so this will allow more acetylcholine to be available, which is going to increase that. So it's going to increase the rest and digest. You want to think about acetylcholine increasing that parasympathetic system, and it's decreasing your sympathetic system. So you may experience abdominal pain, allergic reactions can always happen. So excessive salivation, because your rest and digest is more active, nausea and vomiting, diarrhea, things are moving really fast. But on the flip side, the sympathetic system, you're gonna have bradycardia, confusion, fatigue, insomnia. If you're overdose, there is such a thing called a cholinergic crisis, because it can cause respiratory depression. This is because it's rest and digest, it's increasing, but it's decreasing the sympathetic nervous system. So the antidote for this would be atropine, which is an anticholinergic, so which is the exact opposite. Atropine is going to be an anticholinergic, is going to suppress that parasympathetic system. So the focus is the parasympathetic system. If you depress this parasympathetic system, you can increase your respirations, increase your heart rate back up. So on the contraindications to think about is bowel and urinary obstruction. You should not be giving this because it moves things, but if it's obstructed, it's not good for that. And pregnancy. Beta blockers and NSAIDs should not be given, especially if it's like related to like a GI bleeding. That's dangerous. This can be given as cholinesterase inhibitors. It may be a transdermal patch and a PO taken at night with food. Patch rotates sites and applied to clean dry skin. Just remember that. Patient education, educate the family and patients about the diagnosis and medications, can improve cognitive functions, but does not cure Alzheimer's. Make sure they know that. And stand slowly may decrease the heart rate, causing orthostatic hypotension. Remember that. And especially since you know it's cholinesterase inhibitor, it's going to decrease that sympathetic nervous system. Cognitive abilities, you just want to monitor as a nurse. Does it continue to decline, or is this helping? Is it not helping? Things to consider. So that is everything you need to know for the aging patient of what to expect. So happy studying.